It's my pleasure and my honor again to present Dr. Emer Karen. Dr. Emer Karen was awarded her medical degree from the National University of Ireland, Galway in 1991. Following completion of a specialist training in anesthesia in Ireland, she undertook a fellowship in cardiothoracic anesthesia and critical care and cardiothoracic transplantation at the Freeman Hospital, Newcastle in the UK. This fostered a lifelong interest in organ donation and transplantation, and she had a unique career opportunity arose in 2015 when Ireland separated the donation and the transplantation process, and Dr. Karen was appointed into a new half-time post of clinical lead in organ donation. She's based in the University Hospital Galway and covers a geographical area which comprises 4 other intensive care units. Dr. Karen's keen interest in education and masters in clinical research have allowed her to develop these new national initiatives. Ireland's first organ donation application, which can be found in the application store titled Irish Organ Donation Handbook. And the second initiative is a National Organ Donation Workshop Day. Third initiative is a new organ donation training module for trainees and consultants. She is published work on attitudes and knowledge related to organ donation. Dr. Karen, it's our pleasure to have you today, if you'd like to start.
Manny, thank you. Can you hear me?
I can.
Yes, we do now.
You can hear me.
Thank you.
Dr. Maddy, thank you very much for this invitation, and thank you for the very kind introduction. Okay, so I'm going to speak about organ donation and brainstem death, and I suppose I'm going to give the Irish version of what we do here and try to compare some components of it with what other countries are doing, just to give you a flavour of what we're doing. It's an area that really the education it could be improved, shall we say. And everybody knows about ARDS and renal failure. It's just an area that I think we can just highlight a lot more, and a lot more patients and recipients will benefit as a result of what we are currently doing. So as you see, I'm a consultant in anesthesia intensive care, and I was luckily appointed to a very interesting and exciting job as clinical lead for organ donation. So what I would like to run through, and I will keep time in mind, is the structure of organ donation in Ireland, the opportunities for donation in Ireland, how we would briefly how we would identify a potential organ donor, a clinical conundrums, how we would then perform brainstem testing accurately to diagnose brainstem death with certainty. And then there's some family questions that seem to crop up quite frequently, and I do think if we're not clear in our own heads about how to explain it, we will confuse families and they won't be sure either. And it's really at this point for their benefit, it's not for ours really. So I'll begin. So until about 2015, all organ donation transplantations were conducted through and within one hospital in Dublin. European directive issued that we should separate the donation process from the transplantation process. So this just gives you an outline of what is currently happening in Ireland. There are 6 hospital groups, and I don't know if you can see the mouse on this. So on the Western Seaboard, there are 6 hospital groups. I work in this one, the CILTA, which means the Irish word for lives. Limerick in the south, Cork, and encompassing a lot bigger area than just that. Ireland East West, and then we have the RCSI groups and the Midlands groups. So there are 6 hospital groups. So it means that we have a huge area to cover and we have limited resources. Within this, you'll see we're lucky enough to have full-time organ donation nurse managers for each of these groups. But as doctors, we are either in a part-time or a half-time job. So it's far from the ideal model, that the countries who have the highest organ donation rates advocate. And they advocate that we have key organ donation personnel in every single hospital with an ICU. So we're falling very short, but we are doing our best within the constraints of what we have. But this is our current structure. So for me and my colleague, Pauline May, organ donation nurse manager, who I think is also online, we have this group of hospitals to deal with, and it's a huge geographical area with a catchment area of 1 million people. And the reasons we have the circles are these are the hospitals with probably the higher donors, because Galway is a level 4 referral centre and the others are smaller centres, but everybody plays their part and contributes to the donation process and the transplantation process. So this is the area we have to work with. There's half of me doing this and full-time Pauline doing this. So it's a lot of work to try to get it to where we would like to. So what are the opportunities in Ireland? Talk about solid organs and we talk about tissue organ transplantation. So solid organs, heart, lungs, liver, pancreas and kidneys. We are lucky enough to have our pancreatic transplant service up and running again. Our previous surgeon had retired, but that has now been, we have a new transplant surgeon, so that's great to see. Tissue organs are classed as heart valves, stem cells in St. James's, bone, which can be taken from hips and remodeled for other procedures. So if you draw a line across here from heart to heart valves, if perhaps a patient's heart is not suitable to be transplanted, it's often possible that the heart valves are, and recently the age to consider that has been increased. So that's another positive. So briefly, and there's an awful lot in this and I'm not going to go through it all. So Spain and Croatia are the leaders, certainly in Europe and probably worldwide, if you look at donors per million population. So if you convert, so we're talking about deceased donors and all of this. So they have peaked everybody else, Croatia and Spain, and I'll tell you why in a second, that various things that you think might work have not worked. But they're way up here at 40 and 39 donors. I know the numbers are old, I couldn't get the newer ones, but this is the trend. Now we are down here, if I can find Ireland, we are down here. You might think that's really poor, but the next slide will show you it's not so bad. This is per million small population. But if you look at us in terms of death rate per 1,000 people, we actually have a very low death rate. And this has remained consistent for the last number of years. So if you say we have a low death rate, you have to have a lot of people dying, and a small minority of those will possibly be potential donors, and a smaller population again will be eligible donors. So we're not doing badly in terms of how we progress this process for the families and what the patient may wish. Okay. So Spain are probably 20 years ahead of us in being one of the leaders for promoting donation and achieving higher numbers of donation. But what they've said is these are the things that do not work. Legislative changes, promotional campaigns, all the fancy things, donor registries, donor cards, maybe driving licenses, but how many people in my experience, and I think a lot of us in Ireland, people don't even know that there's a code on their driving license 115 that says, I want to be a donor. So these things that a lot of, I suppose, governments are putting a lot of money into, a lot of effort, don't actually work. It's about the three things that these countries have said that actually work and help the process of donation transplantation are having a key donor personnel in every hospital and intensive care unit. We have 5 intensive care units with 1.5 people for that. It's audit, we're beginning that process, and it's education, and we're really doing very well in that in the last few years. So these things do not seem to change people's attitudes and mindsets. Never blame the population if people don't guess we're doing something wrong. And that's probably very true. And I think the Irish population are the group of people who say, do this, oh, we'll do something different. Don't tell me what to do. So these are the basic principles of the Spanish model. We're trying to work with that with the resources we have. So what are we going to focus on? We need a coordinator. We need somebody in each hospital with an intensive care unit. We need audit down here. We need education and medical training, and we will try to address this. But if we don't get it right ourselves as medics, we can't expect the community and the population to come along with what we're trying to promote. So the only thing I want you to look at on this slide is, I'm drawing a line here. I don't know if anybody can actually see it. I hope so. So the potential donor is a person whose clinical condition is suspected to fulfill brain death criteria, and they haven't been diagnosed with that. I don't expect anybody to remember this, but there are certain terms that we do use. And this one down here is something that gives family comfort, the actual donor. So I've had families who've said to me, if there's any possibility of even one organ being retrieved for transplantation, we would be most grateful. And I do explain that at the time of the surgery, the operation, the surgeons may look and say, well, look, we thought the liver might look good, but it doesn't. But this person is still considered a donor, and families get great comfort from even that, because this is what they wanted. That's all I want you to take from that slide, really. So clinical triggers to identify possible donors, potential donors. These are people we're still trying to treat. We're still trying to fix their original problem. And this is the thing that we always try to do. At the back of our heads, 3 or 4 days down the line, they may become a donor, but it's never our primary goal. So clinical triggers, this was developed in Australia, a GCS of less than 5, intubated and ventilated, and this also in many countries takes place as part of end-of-life care. So this is due to an irreversible brain injury, and I'll come to that a bit later on. So these are clinical triggers that we the Glasgow Coma Scale was only developed to assess traumatic brain injured patients, not to prognosticate. So it's very unfairly weighted. If you look at it, I response 4, verbal 5, somebody who's intubated can't say anything, motor response. So you can actually be scored GCS of 3 out of 5 if you're dead, GCS of 3 out of 5 if you're deeply comatose. So this isn't really very useful for what we do. This is a more useful, and forget the right-hand side of the slide, there's an awful lot in it, but basically the 4 score, full outline of unresponsiveness, includes eye response, motor, brainstem reflexes, this is hugely important, and respiratory patterns. Everything's weighted equally. Just want you to know that that exists. I'd like to get that introduced into Ireland, but struggling so far with that. So our figures in Ireland to the end of 2019, in terms of deceased donors, we had 85 people whose organs were donated by their families, very generously donated. The living donors, and that's only renal kidney donors in Ireland, so we had a total of 110. So just to give you an idea, one patient may donate 1 kidney, a patient may donate 7 organs going to 5 people, depending on, so it's very variable, and it always depends on which patients are on the transplant list, and we are not privy to that, we don't know. But last year we had 153, 66, 15 hearts, which is the usual amount of patients because they're listed quite late in their illness, 38 lung transplant patients and 2 pancreas, and again this is because our services we reinstated in the last couple of years. So we're more or less on par where we should be, but the age of our donors is gradually increasing, which brings into the weight standard criteria donors. I'm not going to get into a lot of that right now because I know I need to get on with other stuff. So very basically, for any trainees in the group or just to understand the anatomy of it, I like anatomy, me. So invertebrates, we're horizontal creatures. This is the forebrain, midbrain, and hindbrain. Just in case people think forebrain, midbrain, hindbrain, it's not. It's a bit different. That's just really a by the side thing. But I like stuff like that. So what I try, this is one of the slides I try to explain to relatives why the brainstem is injured. It's very well cushioned by skull, by CSF, by the brain, and it must take, if you look at it, a huge injury to cause death of all of this, to cause death of the patient. Huge injury. And I think that's a slide worth, for trainees in particular, or people who are trying to explain it, to remember how far into our heads it is. It's really not back here. It's not at the back at all. And the only bit I'd like you to take from this, was two pieces really, but the brainstem, the function of the brainstem, it does four things to make us alive. It's responsible for alertness, sleepiness, in other words, coma, reticular activating system. It makes us breathe. It maintains our blood pressure and gives us a heartbeat. Without those things, we're dead. And the way I use this slide in my head to explain to relatives is to say, these are all the other parts of our brain. This is what they do. They make us dance, sing, move around, talk, all of that kind of stuff. But this is the one part that keeps us alive. And for those reasons, wakefulness, breathing, blood pressure, and a heartbeat. I think it's quite a nice slide. So, thalamus and hypothalamus, what do they actually do in the whole scheme of things? So, the thalamus, up here, brainstem, midbrain, pons, medulla. Midbrain, pons, medulla. Okay, thalamus, there we have two, one on either side of the third ventricle. This is the sensory cortex, sensory pathway to the cortex. If I inflict pain on my finger and my brainstem is intact, I will grimace, I will, even if I'm in deep coma, I will react to that. So that's one of the first tests we do in the brainstem testing, is a reaction to peripheral stimulation in the distribution of the cranial nerve reflex. Sensory, that's the most important thing, and a stroke is devastating. Hypothalamus, what does that do? It's more involved with autonomic nervous system and blood pressures up and down, also sleep-wake cycle, body temperature, and very importantly, controls the pituitary, because when we come to talk about diabetes insipidus, that's involved in that. So thalamus, sensory, that's the biggest thing it does. Hypothalamus, temperature, diabetes insipidus, controls the pituitary. So again, another nice little diagram. What is the brainstem? Thalamus, as we said, sits above it. So if you notice, the olfactory nerve isn't in this, because olfactory nerve and optic nerve, their nuclei are actually outside the brainstem. So we don't test them. We can't test them anyway, but we don't test them because they're not relevant to the actual brainstem. So you can see that in a patient who has an ischemic injury or a bleed, ischemia comes from the front of the brain, the forebrain, to the midbrain to the hindbrain. So you may lose brainstem reflexes one by one. You may not lose them all at the same time. So you may have a patient who's coughing one day, has a gag, but he or she has lost their ability to constrict to light because it goes in this sort of pattern. This is just from the base of the brain, and this is more of an exam sort of slide. So how does brainstem death happen? It's quite easy to explain to people and to understand ourselves. The heart stops, you're dead. Well, let's say, forget about resuscitation and ROSC and all that. Heart stops, death. It's quite hard to understand and explain neurological death. So what is the physiology of it? So an injury happens to the brain, whatever it is, it doesn't matter. I have a few nice brief slides on that. An injury happens. So then the brain tries to maintain blood pressure because it's very, very sensitive to blood pressure changes. It's a fixed vault. It cannot regenerate itself. So there's a catecholamine storm, adrenaline, noradrenaline. They do everything they can to try to increase the blood pressure to keep that brain alive. This in turn damages other organ systems, such as it causes pulmonary hypertension, increased systemic vascular resistance, causes myocardial stunning, myocardial ischemia. These are all reasons for some of the clinical scenarios you see. Eventually, you get cellular hypoxia. The brain gradually, unless it's something like a gunshot to the brainstem, if it's a slow process, the brain will die over 3 to 5 days, which is why it takes that length of time to prognosticate. So these are all what we know is happening to the brain that'll cause brainstem death. Nice little diagram here. Normal brain on the left. See, it's nice and high in the head. I don't know if you can see where I'm putting the mouse. Brainstem here, cerebellum. This is blood flow, these little red arrows. So then there's a big swollen brain for whatever reason, doesn't really matter. Reduced blood flow, and it's herniating down through. So if you think at the base of the nose, that's where the foramen magnum is. Anything that goes, when the brain goes below that, that's herniation. So that is a way of keeping it in our own heads as to what happens. So very quickly, this is a normal brain, 10% of CSF, 10% of blood or brain tissue. Then this little brown thing, there is some process, a tumor, a mass, a bleed, whatever it is. Then we compensate for a while. And then once that gets larger and larger, the CSF gradually begins to rise, as you see here, to the point of herniation. Many different types of herniation. The ones that we will see most commonly described or on scans is cerebellar herniation, foramen magnum, or uncal herniation, transtentorial herniation. We don't see these too often. These are the ones that will kill a patient. Okay. So again, more an exam thing. And once there's a problem with increased intracerebral pressure, the blood pressure tries to increase and it moves in this direction, trying to perfuse the brain. So because the brainstem is in here and the pituitary is right in front of it, then we get hypothalamic failure. We get 3 types of failure: cardiovascular failure, respiratory failure, and hypothalamic failure. So going back to, if we went back to a few slides, we'd see the hypothalamus is responsible for temperature regulation. So we do this, we do, as any patient, prevent actively warm. It does cause diabetes insipidus, and I won't get into that today because we're talking about brainstem tests, but that has to be very actively managed very, very quickly. And this is the management that we currently advocate. Large amounts of dilute urine and treated quickly, or the sodium can go up to 170, which creates all sorts of problems. So if we have a patient, 47-year-old female, unwitnessed collapse at home, she's unarousable. In her medical history, she's hypothyroidism, depression, anxiety. We know she's on olanzapine and L-Troxin, and she had a recent prescription filled from her pharmacist. Many of these drugs are empty. We don't know when she took them, if she took them. I'd like to just have 5 seconds to think about this scenario in terms of how we progress to brainstem test this patient. There may be conundrums, confounders there. There probably are. So you on duty, she's in an ICU for 4 days with no sedation. Her GCS is now, she's unarousable. That should really be 2 because she's intubated. Should that be non-testable? This is what we do in this country. She's hypotensive, bradycardic. Her CO2 is raised. She's acidotic. She's got a respiratory and probably mixed acidosis. So the family have been there for 4 days and they say, what happens next? We've had enough of this. And then one of them says, what about organ donation? Can we do that? Can you do that? Is this possible? My question to you, are there any issues in this current clinical scenario? We'll go back 1. Give you a clue down here. We go forward 1. So that's not a normal blood pressure for anybody really. So her toxicology is negative, thyroid function tests are negative. Should we do olanzapine levels? Perhaps. Now we have other issues in that there were no witnesses to this. How do we diagnose brainstem death? Are there any confounders? And do we have a role for the coroner? There's a lot of problems here, really, but in what looks like an initially very straightforward scenario. So she's hypotensive, so we're going to fix that. We're going to go with the Intensive Care Society guidelines and probably the international ones, and we're going to make sure she's adequately fluid resuscitated. We're going to make sure she's CVPs between 6 and 10. Our drug of choice is vasopressin. It treats two things, the hypotension and possibly diabetes insipidus, which I didn't put into the mix here, but it's about to happen, you'd imagine, because she's probably coned at this stage. So we're going to hyperventilate her, normalize her CO2, fix whatever is causing this problem. So you can't, even if they really, really want organ donation, you cannot test this patient according to our Intensive Care Society guidelines in Ireland, because she's hypotensive, she's hypercarbic, and she's acidotic. So we need to fix all of those things. So the olanzapine levels. Now, we had a real issue with this in that, yes, we can do olanzapine levels. At this particular time, they had to be sent to Wales. They would take a week. I rang the forensic lab in Dublin. They said, we can do them. It'll take a week. So this was going to be a huge problem because olanzapine is a very, very long half-life. And a lot of drugs, we look at their elimination half-lives and say, well, within 5 elimination half-lives, we will then test or whatever, consider or prognosticate really. So within this as well, so this brought it into the mix that we had to do ancillary testing. This is not mandatory in Ireland. It is in many countries, such as the USA. Many countries around the world, you have to have either an EEG. Spain have to have a transcranial Doppler. Ireland doesn't have to, but if you cannot test clinically due to a confounder, which is a sedative, then we performed a CT angio to show no flow to the brain, or to look for flow to the brain, I should say. Other issues this threw up, there were no witnesses. Is this now a coroner's issue straight away? Can we diagnose brainstem death? The family want to proceed to organ donation. Will the coroner say yes or no? Because there were no witnesses, we don't really know what happened. So this is all a big problem. It looked like a small one in the beginning, but it wasn't. So we need a known irreversible cause of coma. I won't go through each and every one of these, but one of the big things is we have numbers. Normal temperature, normal blood pressure, the cervical cord has to be intact. If it's reported to not be intact, then it's impossible to do an apnea test, which then makes us go down the pathway of doing ancillary testing. All these confounders need to be fixed. These are all in the app if you're interested in looking at them. Etiologies, we need to make sure there's no pontine hemorrhage, no encephalitis, no locked-in syndrome, no Guillain-Barré, no endocrine problems, no electrolyte, nothing that would cause a coma. And if you've no cause of coma on imaging, it's pretty impossible to go down the pathway of diagnosing brainstem death. So we know we need 3 things: known irreversible cause of coma, absent brainstem reflexes, and apnea in the presence of respiratory acidemia. These are the 3 things in Ireland and in most countries, but these are 3 things that we have to. We had a lady in the last year who had numbers 2s and 3, but we didn't know why she was in a coma. Husband asked us about donation, we couldn't because it would be refused. So you're an ICU registrar for the fun of it, working with an ICU nurse from country wherever random or GY is. You're going to perform the first set of tests in 30 minutes. Are you qualified to do so? You're an SHO, you're the only person in the hospital, consultant is off covering another hospital. No, in Ireland you need to be registered for 5 years at least. Then you also have to think, so the people qualified to do this would be at least 1 consultant, if not 2. They have to be different people. They should not be part or have any bias towards transplantation. In other words, you could not have a renal transplant surgeon or a physician or a respiratory physician. That would be thought of as bias. But then what we are saying now is you set a time to do this. You have a checklist for equipment that you ask this person to prepare. Otherwise, if you're not thinking of it in advance and they're not thinking of it in advance, because it's such an infrequent thing, everybody's running back and forth, in and out, and it just gets a bit stressful. So plan it in advance. We have a list as to what you ask for, your plan to how you perform these. So forget the name at the top, we just had a patient that we made up and called Rhys. So core temperature is below what we would recommend. We need 36. You actively warm the patient, be it fluids, oxygen, bear huggers, whatever it is. This patient is on morphine 2 milligrams per hour, midazolam, came to you from another hospital. So you need to stop those immediately. Calculation, elimination, half-lives for both drugs, bearing in mind hepatic and renal clearance, and that could confound the whole thing again. Creatinine is normal, okay, so, and urinary output is high, so possibly diabetes insipidus impending there. Sodium is, our upper limit in Ireland is 155 to perform brainstem tests, but still acidotic, you need to fix all of these sort of issues. That should read PaO2, apologies. So brainstem, how do we test the brainstem? So this is what the brainstem does. Some nerves are sensory, some are motor. And what I tell families is, I know the brainstem has died because we have reflexes. We have these nerves coming from our midbrain pons medulla that make us, our eyes, our pupils open. If we get something in our eye, we blink. If something goes down the wrong way, we cough, we gag, we breathe. All of these things, I have to make it very easy for them to understand. So before you even perform brainstem tests, you have to think in advance about performing an apnea test. So we would put the patient on 100% oxygen. That's the first thing, and do blood gas. Because the ICSI guidelines would say that the CO2 should be between 4.8 and 5.8. This is all in a booklet that you can find, so I haven't put it all up here deliberately. So we don't test nerves 1 and 2, that's olfactory and optic. Optic makes you see. So cranial nerve 3 gives you some eye movement, but what we can actually test is pupillary function. Make sure you have a dimmed room. Make sure that you have an observer there with you, that you have a very bright light. And some papers I've read recently say instead of just looking with your naked eye, we should have a magnifying glass to detect the tiniest bit of life. I tell the trainees, look for signs of life, not for signs of death. So that's what this nerve does, and it's high up. So if you've got ischemia front to back and you lose pupillary reflexes, that injury will probably descend towards the medulla and you'll eventually stop breathing, if you know the anatomy of. So nerves 4, 5, and 6, conjugate eye movement, corneal reflex. So the pitfalls with this is that you hold the eyelid open. If you're looking for corneal reflex, don't hold the eyelid, because then you're preventing a reflex that may be present. You have to find a way of holding the eyelid above the eyelid, if you know what I mean. And then testing with either sterile cotton wool. You can use sterile little drops onto the eyes as well, just on the cornea. Looking for conjugate eye movement, which would be the caloric reflex. We don't do this doll's eye because it's quite traumatic. And you do as many of these reflexes as you possibly can. If there's a tympanic membrane rupture on one side, you can't do it on that side, just in case there's signs of life and you introduce infection. And you don't have an intact tympanic membrane to actually elicit a response anyway. So pharyngeal gag reflex. So what I tell people to do, and I think it's kind of broadly advocated, is that just suction the back of the pharynx bilaterally under direct vision with using a laryngoscope, because there could be secretions, there could be blood, there could be anything there in the way. And then there was a time that people would just randomly use a tongue depressor to look for a reflex. I don't think you could miss reflexes that way. A little bronchial suction catheter under direct vision with laryngoscope, bilaterally touch the back of the pharyngeal wall, looking for a gag. Tracheal cough, make sure that the passageway is clear, that the trachea is clear. And then we come to the apnea test. So before you've done this, you've pre-oxygenated the patient on 100%, adjust to the respiratory rate to make sure that the CO2 is between 4.8 and 5.8 kilopascals, normal pH. The purpose is to induce breathing in a patient who can actually breathe. And they will do that if they're acidemic enough, which these are the goals: CO2 above 8, pH below 7.30. if you have found any positive reflex, an intact reflex before this, you can't proceed. There's no point in proceeding because there's some part of the brainstem intact. So as soon as you find one intact reflex, you stop. There's no point in continuing. So the purpose of this is to elicit breathing, but try not to make the patient unstable. So you get them into that normal CO2 range, pre-oxygenate them, clamp the tube before putting them on a C-circuit. So these are some of the conundrums or obstacles, but hopefully you'll have sorted all this out beforehand. If there was any medication, sedatives, measure reverse, including neuromuscular relaxants, alcohol level has to be below the legal level for driving. All these conundrums must be fixed before you even go down this pathway. High cervical spinal lesion, that's the problem, because then you are into the area of ancillary testing. So how do we conduct this? So before you start the brainstem test, the patient's on 100% oxygen, clamp the ET tube, connect them to a C-circuit with CPAP. Do a blood gas, make sure the CO2 is adjusted within the recommended levels. 4.8, 5.8. You need to maintain PEEP or you'll de-recruit, the lungs will collapse, and apart from anything else, that's a poor thing, that's poor clinical practice to allow that to happen. Do not place the bag on the patient's chest, because as a patient becomes hypercarbic through apnea, they will become tachycardic, hypertensive, and you will notice a C-circuit bag moving on their chest, and somebody will get confused and say they're breathing. Put them on the side beside the shoulder. So the CO2 should rise at 2.5 kilopascals per minute. So if you know where your starting point, you should be able to predict at what point you do the next CO2 to get above 8. So I know we say blood gases at 5 minutes and then again at 10, but if you say, well, we're starting at the higher limit of normal, then I predict it should be 3.5 minutes. That would be acceptable. And as there's no respiration, when you've achieved the targets of, or these goals, CO2 above 8 and pH less than, that should read 7.3, don't know how that's there. Then you do not need to proceed to 10 minutes. You just conclude the apnea test and say there is no response to, no respiration to acidemia. Do not say following a brainstem test are positive or negative. Nobody knows what anybody means. There's no reflexes intact. Reflexes are absent or intact, that's it. So, and I say to trainees, look for any response. So if you're doing the caloric test, you inject the water into the ear and there's some response in the eyes. It doesn't have to be the perfect nystagmus. Anything at all is a response. So then you just stand down the whole thing and do not proceed. What do you do next? You've diagnosed the patient as having no reflexes. In Ireland, we do two full sets of brainstem tests, including apnea test both times. After the first set of tests, we go and speak to the family and tell them the outcome. We then say we will be repeating this in X amount of time with a different person. We don't give absolute numbers of times because we don't actually know, but the only caveat is as long as you've normalized the CO2 and the pH in between, you can proceed very quickly. So we then ventilate the patient back to normal CO2, normal pH, and our next colleague then should be ready to perform the second set of tests. In fairness, they're often doing something else, doing theatre or somewhere else. That's why we don't give a time. And you speak to the family and you give them that bad news, sympathize with them. At that point, who knows what will happen? They may say, what happens next? Well, we're going to repeat these tests. In Ireland, if we have all reflexes absent after the second set, that's the legal time of death. You speak to the coroner. He or she may withhold donation depending on whether it's something the family have agreed to or not. And that's a whole other different area. This is all a big topic and it's hard to know how much is to bring into every area of it. But I think the family after this need to be spoken to, need to be told this is the outcome. This is awful. We don't think there's any recovery. They may say, what happens next? They may now, at this point, bring up organ donation. At which point you say, well, we'll do the second set of tests. Things that families may say, but he or she is warm. How do you explain that? I see a heartbeat on the monitor, chest is rising. Is this the life support machine? Can you transplant the brain? Would another scan help? I want another opinion. Keep doing the tests. I think you're wrong. These are the things that we need to all have thought about. He or she is warm and the heartbeat. This is only because we are giving oxygen into the body, and we're giving oxygen to the heart that pumps the blood around the heart, which is why the patient is warm. If we stop doing that, and we would stop it, the patient can't do it themselves because they're apneic, then everything would stop. The patient would be cold very instantly, the heart would stop. That's how I try to come up with analogies as to how to explain it to them. And that's also the reason the chest is rising, because we are giving oxygen into the person. So it makes the chest rise. It keeps the heart beating because we're giving oxygen. The heart needs oxygen, and that makes the body warm. It's not a life support machine because we have now diagnosed death. Can you No, you can't. We've been asked this. Would another scan help? No, not because brainstem death is a clinical diagnosis. Yes, they can have a second opinion. Absolutely. We would never preclude them from doing that. In fact, if they want to come in and see the brainstem tests, that's okay too. I think you're wrong. This is a kind of a difficult one. And we haven't had too many of those, but it's a difficult one to try to. I think if we get all this right up to this point, we probably won't have this. I think you're wrong. Conflict. So this is the checklist we use in the Intensive Care Society booklet. I thought I had a picture of it up there. So as you can see, there's preconditions, clinical test by 2 people and all signed off. That's where you can find all of this, diagnosis of brainstem death. I'm not good enough at the computer to flick the pages as some of my colleagues are, but it's in here if you need to access it. This is the Irish Organ Donation Handbook app, which we devised in Galway, which brings us right through the patient's pathway from ED identification right through to the perioperative period. Free to download from the App Store. You'll have to ask me for access, and it's a person individualized, but it's the only one that does exist in Europe. So feel free to contact me about it. And I think that's it. Thank you very much for your time and inviting me. Dr. Maddie, are you still there?
Thank you very much, Dr. Emer Karan. I think Dr. Ahmed will have some questions for you. Dr. Ahmed? Dr. Ahmed Abrati?
He's gone home. Ahmed, are you there?
Yeah, I'm here. Yeah, I was speaking actually. Hello.
All right, I couldn't hear you. How are you doing?
I'm fine. How are you? Thank
you. Good.
So thanks for the excellent lecture. And I have a question here saying, what is the time interval between the first set and second set of brainstem tests?
Okay, in Ireland, for adults, there is no time interval. The only thing that we need to do is to normalize the CO2 and the pH back to CO2 between 4.8 and 5.8, and a normal pH 7.35. So there's no time interval. And I deliberately didn't mention children because this is the same right down to the age of 2 months. So there's no time interval, and it does depend on who's available to do them and resource-wise. And you might be in a hospital where there's one ICU or anesthesia person, and you have to wait for the physician to then go through. So there isn't an actual stipulated time. The only thing you have to do is normalize the pH and normalize the CO2.
I have a second question saying when organ donation is considered by clinicians.
Sorry, Ahmad, what do you mean? When is it considered, or?
When organ donation is considered by clinicians.
It would only be considered when it's very clear that this patient will never recover, because we spend our time trying to fix our patients, trying to get them to recover. That's our primary goal. We never admit patients to ICU to be organ donors and wait for that to happen. We're always actively trying to treat and manage. And I deliberately didn't go into the ICU management of a potential donor, because all of these people are potential donors. In other words, they have not been declared dead, because we're still trying to manage them and hoping that they will wake up. So if we see a patient with anoxia or an ischemic brain injury, if we go back to one of the slides, it takes up to 3 to 5 days for a dying brain to completely die. And it's probably, it might be in the back of your head that in 3 or 5 days we might be thinking about this, but you're still trying to make sure that your patient, you're managing them to get to the point that they wake up, that they're functional again. So it's only when it becomes very, very clear that that will never happen. And part of our examination of the patient every day should involve a neuro exam. So I say to some trainees, well, is the patient's brainstem functioning? And then they go all, oh my God, I never checked it. I didn't do formal tests. Well, no, are there pupillary reactions? Are they coughing? Are they gagging? Are they breathing? Once you begin to lose those reflexes and there are no confounders, that might lead you down that pathway in a couple of days. So there isn't a time as to when you consider. It's not like at 24 hours. It's not at 36 and a half hours. It's very much patient by patient basis, but you have to base it on the clinical picture of the patient in front of you. And you can't prognosticate within 1 hour. That's just not possible. I don't know if that has answered the question, but that is the reality of, because we had a patient last year who, young man in his 30s, had horrendous ARDS, couldn't get him to the point of performing an apnea test, even though 36 hours before that he'd lost all reflexes. We tried to treat the ARDS, tried to do all those things, and then had to get an ancillary test. So it's very variable, patient by patient.
Thanks very much. I have another question saying, what is the difference between donation after brain death and donation after circulatory death?
Okay, so donation after brain death is a patient who is diagnosed, who has a known cause of coma, lost all their brainstem reflexes and is apneic. Okay. Then the patient who is possibly a donor after circulatory death, they still have an intact brainstem and they may still be breathing, but they have a devastating neurological insult above the level of the brainstem. That means they will never wake up, never regain any function. So these are the patients whom we would consider donation after circulatory death based on neurological devastating injury, and it's futile to continue. You either withdraw any supportive management or you consider donation after circulatory death. So in terms of practicalities, the patient who is a donor after brainstem death comes to theatre on the infusions, being ventilated, managed all those parameters. It's a surgical operation, sternotomy, laparotomy, depending on the teams, all of that. The patient who comes to be a donor after circulatory death, that's more of a withdrawal process with comfort measures. If they're intubated, you would extubate them. If they're on pressors, you would reduce them, but making sure in advance that they're very comfortable, not aware. So they're two different processes. And sometimes it's harder for people to be able to see the donation after circulatory death, particularly because these patients come to theatre and theatre staff are not used to patients dying in theatre. ICU staff, unfortunately, that is something that we see on a fairly regular basis. So the difference physiologically is donation after neurological or brainstem death, the brainstem is dead. And the only reason that you are warm and with a heartbeat is because you're giving oxygen. The other patient, the brainstem is very likely still intact, but they have a huge, devastating cerebral injury, and they will never wake up. They will never walk, talk, do any of those things. So what do? Do you leave them like that? If the family approach you, can we donate any organs? This is where you consider doing that, and that's a withdrawal of end-of-life therapies in a theatre environment. And it's a lot quicker process in that you withdraw, you extubate them. If they're on vasopressors, stop them while having introduced morphine, midazolam, whatever things that you're very happy that the person is very comfortable, even though they're comatose. And then there's a 5-minute wait and see if they're asystolic, wait another 5 minutes, and then the retrieval starts. So it is a very rapid process. And something that staff have to be educated quite clearly on, because it's not something that many of our hospitals do. I think, well, Beaumont do it. 3 other hospitals outside of Dublin, Galway being one, Limerick and Cork. Limerick and Cork have both done this, and it takes a huge amount of education. It's not something people are very accustomed to, even though this was more the norm before the criteria for brain stem death were introduced in 1968. Ahmed, stop me if I ramble. You know how to stop me.
No.
Stop me if I ramble. You know how to do that. Just say stop. You're talking too much.
So the next question is about your family approach. I know it's different between the cultures, but we are taking the Irish approach here as a model that we're speaking about. So how you approach the family, and when you discuss the brainstem findings with the family, how can you convey this knowledge to the family?
Okay, so if you want to take a very clean canvas, in that this is a devastated family, they're totally in shock. We're 3 or 4 days down into along the line of treatment. I'm going to make this a very easy scenario. Then it's very clear this person has been off sedation. Say we have a 20-year-old who hanged himself, we'll say, just to make it very easy to understand. And no brainstem activity, no drugs, no sedatives, no muscle relaxants, no endocrine problems, no sodium abnormalities, no sugars, and there's absolutely no response to any clinical examination. There comes a time that you have to, this is part of your neurological examination every day. Maybe not every single brainstem test, maybe not the caloric one, but yes, and then you have to inform the family that, look, this is looking really terrible. We have given, I'm going to say Max, I hope there's nobody here called Max, X amount of days. His brainstem looks like it's not functioning. If they want a scan, we do a scan. But then you give them the terrible news, but you then leave them alone to give them time to absorb this awful news that you've given them. Some families, we're finding more and more, they're coming to that conclusion themselves, and they might bring up the topic of organ donation. But until we have done formal testing, you can't say yes or no. So if you keep it really clean and simple, patient who has lost all their brainstem reflexes, is apneic, no confounders, you go and tell the family, look, this is looking really terrible. We're going to do a set of clinical tests, and I'll come back and talk to you after that. And assuming, and you should be very confident that you will not find an intact reflex, because you should know this at this stage. You go and you tell them, and you sympathize and say, this is looking really, 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 really terrible. I don't think he's going to recover. We'll do another set of tests. Then they might say, what happens now? We'll do another set of tests. They might say, what about organ donation? You see, you never know what families will come up with or what timing, and you have to be ready to be able to handle it. If they say to you in A&E, oh, she's 6-year-old, she's had a terrible bleed, what about donation? You go, no, far too soon. We will bring her to ICU, we'll try to manage her, we'll try to get her back to a point where we can predict what might happen. And I know I'm giving you like 3 or 4 different scenarios, but that is the reality. There is no, at 12 o'clock we'll do this. Do you know what I mean?
Yeah, it's just for the clarity between the different examples.
Sorry?
So it's just to convey the clarity when you explain different examples, so people can get an idea from each example. How can you approach?
I think as much as possible, you keep it very simple, and you, and a lot of the time we wouldn't ask the trainees to do this, really, to be honest, because all sorts of things get thrown in your direction, and it's very hard to manage a lot of them. But unless we do brainstem testing and we have explained to the family in advance, I would not mention organ donation. It's premature. That you haven't even said the patient is dead. I think it's a very wrong thing to do, and we would not advocate that in Ireland. You only mention it when you know the patient is dead, but the legal time of death is after the second set.
Thanks very much, Dr. Karen. Another question here from Islam is saying how far the medical legal aspect will affect your decision for donation.
In what way?
He didn't specify. It's just a vague question. I think that's related to different cultures where the medical legal aspects has effect on will they go for donation or not. So it's not coming from the Irish culture where that's not a problem.
Well, we always ask the family or the next of kin for their permission or their assent, consent. The medical legal aspect to me doesn't really exist in this context. If this is something a family really want, I will do everything in my power to make it happen. So there's nothing. The only medical legal aspect to this is if the coroner refuses donation. And the coroner may refuse that. So say if I was shot through the chest, the coroner might say, well, you can probably donate the liver, but I want to look at the heart and the lungs. That's called a restrictive post-mortem. So in Ireland, we don't have legislation telling us what and what not to do. I know there's some countries that say that donation has to happen regardless of what the family says. That is not the case in Ireland. Regardless of any legislation that might come in, we still go to the family, the next of kin. If they don't agree, then we step away from the whole thing. So some countries would just retrieve organs regardless of what the family say. I don't know the implications of that legally. Luckily, we're not in that position here. The only person who can say yes or no really is the coroner. And the other thing with that is that we have to then explain to the family, the guards will come to identify the patient, and then they think there's something wrong, but it's only because the guards are a deputy for the coroner to make sure that is the person we say it is. Now, I'm not sure what the question really gets at, so I don't think I've answered that particularly.
Yeah. So we have only the last question here. If the donor has a blood transfusion during the current hospital admission, does this exclude him from becoming an organ donor?
Not necessarily, and it's a very good question. So there is the process where we take, so say if we have gone to the family, first set of brain stem tests, they want to donate, then we take a set of bloods to send to labs in Dublin to look at virology, to look at HLA antigen typing to see if they're a match. So the only question we will be asked is, say it's a trauma patient. Did this person receive a blood transfusion in the previous 48 hours? So say I'm referring to Dublin now at 20 to 9. So go back 48 hours. Did this person receive a massive transfusion or any transfusion or blood products in the last 48 hours? And that doesn't preclude you, but it might dilute the antigens. So we just need to tell them in Dublin, say how many blood red cells, how many FFP, how many, but it doesn't necessarily preclude at all. It just might change things. They may have to change their recipient. And no longer do they preclude patients or people who lived in the UK. And that was a thing once upon a time. You couldn't be a blood donor and you couldn't. So no, it doesn't. This is where you pick up the phone and ring organ donor, nurse manager, the clinical lead, ICU person, because it doesn't preclude anything. The only things that preclude donation are refusal from a family, refusal from the coroner, a transmissible malignancy like malignant melanoma, transmissible infection like rabies. Even in Spain, they're now transplanting organs from COVID positive patients. HIV is not a preclusion either, so neither is a blood transfusion.
Thank
Does
you
that
very
answer?
much.
Does that
Yes,
answer?
Of course.
The answer is no.
Yeah. Thank you very much, Dr. Karen. That was very interesting and very excellent lecture. That was the last question.
Dr. Karan, 1 second,
Yes,
Dr. Ahmed.
yes, Dr. Mahdi.
I don't have much experience in ICU like yourself, but do you think by this Corona episode and the pandemic and whatever, do you think the brainstem testing is going to be changed, especially the gag reflex and something like that, or in the near future? Are we, despite I know, despite we are taking all precautions, PPE, and all of this stuff, do you think that would be considered in the near future?
I don't think so. So if when we are referring or think about referring a patient to the transplant surgeon through the ODTI, we are asked to perform 3 swabs as close to the time of surgery as possible. We have devised a lot of pathways for intubation, extubation, tracheostomies, which involve covering the patient's face with plastic, extubating into that, putting on a face mask. So I don't think it'll change any of that, and it certainly hasn't in our experience. There was a brief period over the summer where the renal transplant surgeons suspended their service, and I can understand why, because they could maintain their patients on dialysis. So, but the service is back and running as normal, and it hasn't changed any of how we perform brainstem testing. But if somebody, I think you'd have to be very sure anyway that the patient didn't have a gag or a cough anyhow, and you would know that a couple of days in advance. So we would perform tracheostomies. We looked at a few different devices to cover the patient's face and neck and do it underneath all of that with PPE. But so far, no, we've had nobody who's been positive in my experience. And it hasn't changed the way I think any of us or our colleagues have performed gag or any of those reflexes or suctioning or anything. It's a good question though, but I don't think it hasn't changed anything.
Thank you. Dr. Amr Salam, welcome back.
Thank you very much, Dr. Saad. Very much.
Hello, Amr, how are you?
Being great. Yeah, thank you very much for that brilliant lecture. Actually, I did enjoy it fairly well. I just have a question.
Sure.
Involving the COVID status and everything, we lived like a tough days in the last few months. And do you think with the COVID, does it affect any aspect of the transplant itself all over the world? I know that Spain started to transplant patients from COVID, but do you think it affects them in the lungs or the heart or something like that more in the organs?
Now we've been asked to provide 3 negative swabs as close to the time of retrieval as possible. As long as one of them is a deep tracheal or a BAL, then the surgeons in Ireland certainly are happy to proceed with that.
But with the positive result, they won't proceed, right?
Sorry, say again?
With the positive results, they won't proceed for the transplant.
I don't think we've had anybody that has been positive, and in Ireland they may not at the moment. But at the same time, because you have to think, they probably have not consented the recipients to receive organs from a COVID positive patient, whereas other countries have had this disease before us, so may have changed their consent policies. Because we've had that with a few different diseases where in Ireland, they've changed what they consent patients for. So I think, I'm not even sure we'd refer somebody who's COVID positive because, we've a small population of transplant recipients. I don't see where we've actually transplanted anybody like that. And I'd say if a possible donor was positive, I'd say the transplant surgeons would say no, for now.
Thank you very much. Thank you very much for that.
Are you okay for another question, Mr. Karan?
Sure, fire ahead.
Yeah. So a question here came, just comment on the Doll's eye sign as a brainstem test.
It's not something that is currently in our Intensive Care Society guidelines. So that's been superseded, I suppose, by the caloric test, whereby the patient is at 30 degrees, you inject, people say different things, but 50 mils of ice cold water into an ear that has an intact tympanic membrane, which you can see. And the normal response is, say, if you're injecting it into my right ear, I'll look to my right as if to say, what are you doing? Then I'll have the fast response rate away from that, as if to say, get away. So I think it's a safer test to do, because, you know, neck injuries, would you want to create a bit of problem by doing the Stahl's eye? That has gone out of our guidelines, so we don't do it anymore. And if you can do the caloric test, which you can in most people, you just don't even go there with the doll's eye at all anymore. I do think it causes trauma, and I think that's why it's been left out of our guidelines.
Last question from the floor.
Yeah.
Okay. What happens if the families is changing their mind?
Then you just leave them alone. If there's conflict, if there's any degree of disagreement, you cannot bring them down that pathway, because some of them will resent it forever. Then there'll be fighting between them, and we walk away from all of that, you know, and you just cannot. And what we're finding a little bit more now is people are having second families. People are maybe still married to somebody from 20 years ago, never got divorced, but they're with somebody else, and there's no legal next of kin in Ireland, and sometimes that causes conflict. And if there's a degree of conflict that they don't resolve themselves, we just say, okay, that's fine. Thank you very much for even considering it. We leave it alone. We've had one group of, yes, the traveller community are a little bit different. We've had a group who, I think they may have been based in the UK at one point, where they might be, you know, thinking a bit more forward or something, and they approached us. Can't even remember which hospital, doesn't really matter, about donation. But there are no religious preclusions, there's no cultural, apart from this group of people who just will disagree. But if there's a family conflict, we just leave it alone. Okay. We had an interesting, I wasn't involved in this, but a Muslim family. The lady was brainstem dead, but the family didn't agree with brainstem death, but they wanted to donate, but only after donation, after circulatory death, when her heart stopped. And I do think it was in Galway before my time, but we didn't have the facility to do that. So there's all sorts of little things that are thrown up each and every time that are just take us by surprise. So, but to answer your question, if there's family disagreement, we walk away and leave and don't pursue it. We don't have to live with the consequences they do.
I think time.
Another question came here, if that's allowed, Dr. Saad.
Okay, last one, because otherwise we will stay here forever. You know,
yeah.
Dr. Emer Karen is very kind, and we will take her all time tonight, you know.
We're just taking the opportunity to ask her a lot of questions here. So
I know that, Ahmed, go on.
The question is saying, is malignancy of any kind is considered a contraindication for organ donation?
Yes, malignant melanoma, always, because that will reoccur sometime somewhere. Cancers where patients have been, say it's a very stage 1 cancer, they've been clear on scans for 5 years or more, bowel and breast cancer, that's not a contraindication. But this is where it's so important that we get patients' charts, characterize them, which means getting their full entire history, getting histology, looking at margins, looking at all of that. You can never say no, and it's not up to us to say no. This is why we gather all the information, characterize the disease, if you like, and the surgeons will decide depending on who they have on their list. You may have somebody who is 23 years old, end-stage liver disease, and say, I've had cancer 5 years ago, and that person might say, fine, I'll take my chances. But it's not a contraindication. A transmissible malignancy such as malignant melanoma, disseminated malignancy, of course, but a primary brain tumor, not necessarily. and a cancer that has been curative, say it's even if it's a prostate one, they'd want to know exactly where the radiotherapy was, all of these sort of issues. So we can't outrule anything. We can almost always outrule malignant melanoma and something like rabies, you know, transmissible infections. But say I had E. coli in my urine, no, you just treat me as the donor with the sensitive antibiotics and then do the same for the recipient. So this is what's called expanded criteria donors. So you have to look at each and every malignancy. If it's a malignant melanoma, and that's going to be a no. Then other skin lesions, it's called body mapping. You turn the patient, you look for scar signs, you look for moles, bumps, or tattoos or any of that. These are all things that we can do very easily at the bedside. So melanoma is one of the biggest ones. A recent cancer that has, you know, in lymph nodes, that's going to be a no. So a lot of the time there are no hard and fast rules, but there are a few with the transmissible infection, transmissible malignancy. I don't know if that answers your question, but melanoma, forget it.
Okay.
I think that's clear.
So, Ahmed?
That's the last thing.
Okay, we have to conclude this international webinar tonight. Professor Maged Salah started the hemodynamic measurement through the Doppler and transvaginal echo, and Dr. Emer Karan taught us about organ transplantation, organ donation, and the brainstem testing in this unique, distinguished lecture. Thank you very much for both of your time tonight, and I really got benefit a lot from these two lectures. Amr and Ahmed, do you want to add anything, please?
Thank you very much, Dr. Salah. Thank you very much, Dr. Emer and Dr. Maged Salah, for these brilliant lectures. Thank you.
You're welcome.
Thank you.
Thank you, and you are welcome, and happy to meet you with you in your mega online course.
Thank you very much, Dr. Maged.
Well done, Dr. Madik. Well done.
Thank you very much. Thank you very much.
Thank you, and very nice
Thank you.
lecture.
Thank you.
Bye.
Thank you. Thank you, everyone.
Thank you.
Thank you.
Thank you very much.